Yeah. Dear Facebook Pure Urology viewers, good evening one and all. As you all know, every alternate day we are conducting surgical technique based related to urology in this forum. This Pure Urology group contains 6,500 urologists across the world, and this is the 128th program we are doing. Today is a special day because one of the senior most urologists of the India, who has dedicated his career to the urology, Dr. Mahendra Bhandari sir is the speaker. Actually, today we thought in a different way, not only the subject on the technique, but also for the young urologist, little bit of guidance we can take from Professor Mahendra Bhandari sir. To my knowledge, when I have done my MCH urology from PGI Chandigarh in 2002, first time I came to SGPJ Lucknow when laparoscopic donor nephrectomy was a live workshop. That is the first time we came to know the director and the head of the department was Dr. Mahendra Bhandari sir. Since then, we all know that SGPJ is one of the institute which is preferred by all the urologists who pass through the post PG exam. Today also, after the NEET as well as the post PG exam, DNB both are MCH and DNB both are preferring SGPJ because of great involvement by Dr. Mahendra Bhandari sir in evolving the institute, particularly urology. After that, the director of the SGPJ and then various positions. So let us listen from him two aspects today. One, every young urologist want to aspire, want to become like him in their lives. Everyone is in the competitive field. Everyone gets urology seat out of lot of competition. Everybody dreams their career to go abroad, to settle in India and make a good academic career. Most of them think like that. Second point is, every time we have to take the challenges. Once upon a time it is open nephrectomy, open pyelolithotomy, now the era of the robotics. In that sense, Dr. Bhandari sir has balanced his life over a period of more than 50 years. Let us listen in 30 minutes to 50 minutes all about his career so that we get encouragement and enthusiasm to think further. Good evening, sir. Doctor, for you, good morning. For us, good evening. Good evening, good morning, sir. Dr. Mahendra Bhandari, sir.
Thank you, Chandra. Thank you for inviting me. It's always a pleasure to speak to young people because that's what keeps you young.
Yes.
And really appreciate your sentiments. And I don't know where to begin, but let me tell
Sir,
you.
I like to ask first question is where is your MBBS, sir? This is usually my first question.
Yeah, I did my MBBS at SMS Medical College, Jaipur.
Oh, great.
See,
After
what
that,
I
you did MS from, sir?
MS from the same institution and then MCH from CMC Vellore.
MCH, which batch you belongs to, sir?
I belong to 75. I graduated MCH from CMC Vellore.
Who was then the head of the department and mentor, sir? Who are your teachers?
My mentor for all times was Professor H.S. Bhatt.
Oh, great.
Urologist, I call the urologist with least of means. He never depended his quality of thinking and patient care on
Sir.
the gadgets, where the focus for us is the gadgets. And so I really have very fond memories, and he is my mentor. He is my role model.
Sir, what was the reason why in India so early CMC Vellore has been so successful in nutshell in academic any not only for the students now for the patients also. It's in India it was one of the best center for the treatment also. If you go to the past history before your career started, what is the main difference why CMC Vellore has been so popular?
In one word, there is dedication in the air you are there. There is a sense of dedication. And here for youngsters, I'll tell you, one small incident how the medical institutions are different than CMC. CMC is different than other institutions. I was a young first year resident in urology, and in Jaipur, we had, to be honest, we had a very laid back career after MS, and we will definitely look after patient care, do quality of surgery. But the sense of dedication I learned in CMC a lot. That one evening, when I was about to leave at 7 o'clock, Dr. Bhatt's morning would begin at 6 o'clock with rounds. And it was like chasing a goose. If you miss him for 5 minutes, it would be hard to find out because he'll have 30 to 40 patients in private ward, and every patient he'll see before going. So my sister said that one of the patient is having a GI bleed, on which Dr. Bhatt had done an open prostatectomy. So I went there, and as usual, I did ordered the investigations, ordered the blood check parameters, started gastric cooling, and sent a reference to a gastroenterologist. And this gastroenterologist changed my way of thinking. Cyrus Kapadia is the name. I don't know him after that, but that is in my mind. So gastroenterologist came with the bag at about 7 o'clock in the evening, and usual consultation is they'll come with the resident, advise something, and walk out. Cyrus Kapadia picked up the patient care stool and sat down on that stool. And I remember that he did not leave the patient till 4 a.m. in the morning, till the returns were clear and patient was stabilized. Now, as a junior resident, I had no other option than to wait there, though I was feeling silly that why the hell, it's okay, nurses will look after, we'll get called. That is the difference in the dedication that comes from your inner self, that you don't do for achieving your MCH or pleasing your bosses. I think this incident, and one more incident I heard, when you go to the basement of urology, we used to go through hand surgery, and you get down to the department, there was a big written, director was KG Koshi, and it was written there that as a resident, first thing which attracted my attention was that if this patient is always right, if as a resident or an employee, if you are having any altercation with the patient, you would be questioned, not the patient.
Yes, sir. So
That level of dedication, you can see that.
yes, sir. Great. Sir, that time who was the other department consultants? Were there any foreign consultants? And how are you related to again two teachers, Ganesh Gopal Krishnan sir? How senior, junior to you in the MCH CMC Vellore, sir?
Okay. My other teachers I remember was one of the excellent surgeons, Dr. K. Dharman.
Sir.
He was one of the finest surgeons and a finest human being, and I kept my contact with him for several years. He was in Syracuse, and Dr. Dharman I remember very fondly. And of course, Dr. M. Mohan Rao, who was my mentor for the kidney transplant. And
He is from our state, actually.
yeah, and I joined CMC at a crucial time when they had done just the first 30 transplants. And my birth became from, people say that the characteristic of a cricketer is known from womb. And even before I joined the CMC formally, I did 3 donor nephrectomies for him. I was visiting as a Hindustan Warner's traveling fellow. This was a fellowship given to a urologist by the Association of Surgeons of India. I was not, there was no urology society at that time. We were part of ASI. And I got that, and there I spent 6 weeks with Dr. Mohan Rao. He was very difficult to begin with, but within days, he had so much of confidence in me that he asked me to do a donor nephrectomy because my colleague Vasant Krishna was on
Yes.
leave. They were hard up for that. So, and then he offered me this position, what you call that whether I would like to join MCH or not. And that's where my career got into roller coaster.
Great.
The question you asked about Ganesh and Kandaswamy, they were junior to me, I think, couple of years junior to me, and I did not know them at as much at CMC as I knew them at what you call in All India Institute, because after my MCH, I went back to Jaipur as a lecturer in surgery because there was no position in urology. And within less than a year and a half, I got selected as lecturer in urology at All India Institute of Medical Sciences, which was a position created. Only 2 faculty positions were there. And this was a position created after several years of the inception of the department in 60s. And then I got selected there. And that's where, when it so happened that everybody left the department, Dr. Pandey was the only person who was 1 year senior to me there. And the MCH requirements needed that these people should be sent to different places. So Professor Mansingh at that time accepted them. And we had the pleasure of having both these people working for several months on rotation to complete their requirement for MCI. So I know, and since then, they really, Kanda and I were great friends, and I was quite witness to how he developed the first Vedanayakam hospital. I used to visit him in Coimbatore, and Ganesh, of course, we have been frequently interacting. So.
But during your MCH, which surgeries you are keen? I mean, how was your open surgical skills, and who was your mentor? What you had in your mind? Because urology afterwards has become much endourology and laparoscopic urology. But at your era, it was like xanthogallanomatous pyelonephritis, nephrectomies, transplantation, more of craft work open. How you thought, and what was in your mind?
Let me tell you, at that time, as a urologist, my memories are still fresh. Only 2 ambitions I had.
Sir.
And every urologist would have. One is to learn transurethral resection. And another exciting baby was kidney transplant program. Only 2 things differentiated a urologist from general surgeons.
Yeah.
And otherwise, everything was open surgery. But let me tell you, that the concepts, the way the patient bedside manners, analytical process, keeping your knowledge update was no different. In fact, it was much more better. I remember having had arguments with our seniors when they will visit, like Venugopal, for hours in the presence of Dr. Bhatt, whether a tubercular kidney non-functioning should be removed or should not be removed.
Yeah.
Gopal said had that feeling that a sleeping snake, anytime it will wake up, and he's right, that we have seen in my career that a dormant tuberculosis becomes active after 39 years, and you prove in the cultures, or 40 years. So it was the depth of thinking. It was approaching a patient with no other consideration except for the problem of the patient.
So in the aims, then let us come to the main point, the SGPJ. I hope you joined after it started from the aims to SGPJ, it looks like. And who was invited to SGPJ? And in relation to the Lucknow, what is your native place, sir?
Okay, it's not. You missed my plum career at Zipmer Pondicherry for 9 years before I joined SGPGI.
Oh, you were in Jipmer, sir. Sorry. Okay.
Or for after I finish, when I was doing exceedingly well, Professor Mansingh, I was his most blue-eyed boy, and very high quality surgery we were doing, from renal artery stenosis to what you name a thing. And AIMS was a wow place to work in 70s. And nobody would leave. Everybody would die at AIMS as faculty. Number one, you wouldn't get in easily as an outsider, but if you get it, nobody would leave, because that was the best academic position available in urology. But somehow or the other, my intuition said that UPSC offered me a associate professor's position at the Government of India job in Pondicherry. At that time, it wasn't an autonomous institution. And I picked that job simply because my inner self said that is the place I should go. And my parents were alive, and we did not know where the Pondicherry is. So we had to really look up in the map, and there were three
But
places.
exactly, sorry, sir, but exactly going from Ames is not a good decision, is inside feeling for anybody. Why you moved to South India, Jipmer? That time Jipmer might have not got this name like Ames. What made you to take such a major decision? You might have as well became professor in Ames also.
Yeah, so you are absolutely right. There was a lot of conflict and ego in it, because going from a place where there were 27 people in the department, you were one of the three faculty members, and to going to a place where I was the head and I was the tail, and there was a Braunberger cystoscope, which had a catheter. And as I pulled out the catheter, 7 French catheter, it broke inside. So probably several years this scope was never used. That was the state of infrastructure. But I went with only one conviction, and again, Dr. Bhatt's teaching, that it is not the gadgets. It is not, it is you. It is your thinking. These things will follow, but the patient gets well today not because of robotic surgery or endoscopy surgery. It is because of what decision you have taken for him, what is right for his problem. And that was my conviction. And then when I go to Zipmer now, after 40 years, the foundation is totally buried. Nobody knows the history of the department, but it is one of the premier departments in the country now, with best faculty members and up to robotic surgery and everything. And
Yeah.
there I would like to remember my colleague Santosh Kumar, who helped me to start the Indian Journal of Urology. And I think my 9 years at Zipmer was a great experience. This advanced my career by 10 years. And thereafter, I was invited to join this new department at a new institute, which had been built in 78 or 80s. But no, it was not taking off, and we were one of the 5 professors. I was fortunate that I inherited 6 months before Rajesh Allawat and Anant Kumar were selected. So I already had one of the greatest teams I could dream of. And then Rakesh Kapoor joined the bandwagon, and then there was no going back. But we started the institute when there were no marble, no flooring done in the hospital, but we started operating.
In Jipmer, who are the known contemporaries? I heard Mani Menon sir is also from Jipmer. Was he a bit junior, sir, something? Did you attain the professor post in Jipmer, or you were in assistant professor only, sir?
Yeah, so I joined as associate, and I was, of course, by the time I left in 88, I was already 4 years professor and chairman of the department. Chairman, I was right from beginning. Mani Menon is a very important mention, because Mani Menon had a lot to do with my subsequent career even now. And Mani Menon was not, he was my contemporary, and he was a student, alumnus of Zipmer. So
Yes, sir.
everybody, whenever they meet me, they will talk of him. And he was at that time just completed his residency from Hopkins and joined as faculty in St. Louis. So I wrote to him. I was doing a workshop on stricture urethra, and his work was on oxalate stone and metabolism of mitochondria and all. So, but I wrote to him that I'm doing this workshop, and this is your alma mater. I'll be very happy if you could come. So he wrote back immediately. In those days, no email, no faxes. It was just the snail mail. And he wrote to me back telling it would be my pleasure to come. But somehow or the other, I have a commitment in Trivandrum when Fazil Marikar used to do a stone meeting, and I can come after your event. So he came and spent 7 days there. And since then, we have been back and forth visiting each other every year on average we'll meet 2 to 3 times wherever he went, and he used to come to Lucknow. So
Uh, the most important part I wanted to ask is what what is the main apart from your, I mean, just now I came to that they are 6 months juniors. I have seen Rajesh Ahlawat sir operating partial nephrectomy in Hyderabad. I have seen Anant Kumar sir, of course, of my age group, anybody, because he was my examiner, and the amount of the knowledge he has in renal sciences is amazing, especially both physiology as well as the pharmacology of the transplant medicine. What three of you, in fact, you being the head of the department, made that marble level SGPGI to the marvelous position, so that all these students, even sorry to say that I am from AIMS MS, MCH from PGI. I did not get SGPGI, but I was wishing my first choice for SGPGI. What is the period this transformation? People say that you identify the talent and independently give them full freedom to grow. That is number one. Number two, honestly, you made the equipment to be available to the department. Number three, you identify each person's ability and put them into the proper direction. This is what we used to heard. I wanted to listen so that the youngsters also think like that. It's a sort of leadership quality. What is your comment on that, sir?
well, partly you are true and partly it is not true. Number one, I did not select these two gentlemen.
Yes, sir. That's I
I
came to
was
know just now.
fortunate to have these people. And number two, I did not, yes, I did. I was very much equipment savvy, and I had a privilege as a head of department to get new tools. But most of the equipment was already waiting because of the Japanese grant, and they were all in crates. And we were fortunate to begin with a very well equipped department. But it was just the equipment. There was nothing, no blood bank, no labs. We were 19 miles away from city. There was no anesthesia when we started our first case. So somehow the other, putting it together was a pleasure. And then you ask me why secret of success is not Mahendra Bhandari. It is because of these three giants I had, including Rakesh Kapoor.
Yes, sir.
And all we had was we had redefined the competition. I can tell you, I learned a lot. We redefined that it was not dog eating dog that you talk to number one and number two. They would be good, but they are always having tensions. We never had tensions because we were very communicative. First thing I told the director when I went in, that is it possible for me to have a big table in the office, because we had different offices, because I want everybody to be sitting with me. And I handwritten made a poster, I and we, and I made a cross on I. So it was we. And just I'll tell you how we worked as a team is something everybody need to learn. And we will go with aspirations, young people, that today I will do a continent diversion and cystectomy, and somebody will come and say that, could I do this? Would you go and do a staghorn? Or would you do a urethroplasty? And there would be nothing, no patient belonged to anybody. I remember having done, again, I'll use incidents to elucidate what I say. There is example for that. I did a radical nephrectomy, nephrouretrectomy on extensive transitional cell carcinoma of the renal pelvis, extending down up to, and we removed the thing. There was extension of tumor outside the ureter, and this patient started bleeding after the kidneys out. This was the first case I started. Until 4 o'clock, I was struggling. We would have given 18, 19 units of blood. And at 4 o'clock, other colleagues, Rajesh finished his list and he came to me and he said, now enough, you go and have a coffee, I'll take care of it. And I went in back and I did not get a call. So I thought he would have fixed it up, but I was anxious. In the morning when I saw already 4 times the patient was operated after Rajesh, Anand took over the case. And then again, Rajesh came in, there nobody called. So we never identified the patient with a consultant. It was a no man's clinic. And we ran what you call disgruntled patient clinic as a chairman, because every surgery would not go well. And some cases would really get into intercurrent complications. And once I found a patient struggling to get well in a clinical pathway, I would own that patient, means everybody is involved in the treatment, because it helped me. Otherwise, next day from city or some politician will call, would you see this patient? And then I always say, no, I'm already seeing that patient, though it has been operated by so and so. So it used to be a consensus decision about these patients, some good practices. Everybody had aspirations. And as a chairman, my job was not to compete with them. My job was to give them an environment to grow. And mind you, this department was resident focused, because when I came in at this place, this is very important for you to know. This department, we had resolved that our trainee would be the best in the world. And why this came in, because in UT conference, there was a symposium on transurethral resection, and one gentleman came and said that he quoted me there, that a teacher who competes with the students is not fit to be a teacher, because we will be dying to see transurethral resection, because there were no teaching attachments, no video scopes to see what the surgeon has done, and surgeons will not give the things. So when we came to SGPGI, we had an opportunity, and we said our residents would be the best. And my faculty respected that. And you see that it was, we'll do 2 transplants in a day. And we'll go by time, that if by 10:30 the resident has reached well and has not created problem dissecting the hilum, we will just go scrub and stand for him to do. Otherwise, he will do the whole surgery. Residents did anastomosis depending on their level. And that's why another thing, we kept the 3rd year. We were one of the programs after Manipal, which started with 3-year program. And 3rd year was only for doing complex surgeries, which they could not do. They would be always junior consultants, like if he hasn't done augmentation cystoplasties, urethroplasties, if he wants to do some radical cystectomies, 3rd year would be for that period. But then subsequently, it so happened that people, exams were over, they passed out, some of the residents became non-serious, and they would be absenting all the time. So then we changed, when I was the director, that no, exam should be done at the end of it. But everything was built to suit the resident, because our focus was, we will anyway learn, but the resident should be so confident. And it is so true that when I go to a place and find that take Chandra. First thing, if a patient tells me that he has had a surgery in Preeti Hospital, and if I don't know, I said, who is the urologist? Chandra. First thing I'll think of is, where was he trained? Either you are good or bad. So I think, again, I bring Dr. Bhatt, that when he was given the award at ASI for development of specialty, he said, he was asked to say something, and he said 2 sentences. He said, in your career, spend your life in working for your residents. Give them everything what you have. And believe me, every feather in their cap is indirectly in your cap.
Yes, sir. So, one tough question, sir. SGPJ being 14 kilometers from away, even my colleagues who have done gastroenterology, they are all doing well. Many of the departments have chosen as the an hospital, that too government-based hospital, that too situated far off in Lucknow, which is not a very famous metro city. Even now, it is not in the top 10 business centers. How the patients have come, how the other departments are correlated, which year to which year this transformation has happened, that it became a huge referral center. And then when you became a director, what was the situation?
We started in 1988 when I joined, and as I said, the first batch of faculty joined in 87 June, and I came in January 88. And at that time, buildings were there and equipment was in crates.
Yeah.
And when I came, I talked to my faculty, three of us, myself, Rajesh Alawat, and we talked and we said that all of us came from a very busy clinical practice. We would be operating, I would do 5 to 6 strictures in a day in Zipmar. And so we were rusting there and nothing was happening. And because the bottlenecks were such that you can't do blood investigations, you can't do labs were not there, there's no transfusion service, no anesthesia. How do you do it? And in one departmental meeting, the three of us, there was nothing else than to eat samosas and have meetings. So I told them that I am deciding a date that 30 days of now, exactly what is the date we will do the first surgery in this department. And he said, how we will do it? And fortunately, director was very dynamic, Dr. B.B. Sethi, and he had brought me with a lot of effort. So I had an access to him. And one day I went in his office and I said, I want you to sign a blank paper for me 30 days after I have a transurethral resection, because patients were contacting me and we were not doing it. A retroperitoneal fibrosis came and I said, no, I'll send you to Dr. Kulabawala because I can't do it, because my infrastructure doesn't support. So Dr. Sethi said he was itching that some department starts. And so he said, okay, this is a blank pen, you bring and I'll sign it. So we made the lists in the department and then we looked for an anesthesiologist who was Dr. Das's wife, who was very good anesthetist, but she was not a faculty member. So I took permission from director whether she would be able to give anesthesia or not. And director said, no problem, we'll do something. Then we had a transfusion. I didn't want to begin the first transurethral without transfusion facility. So we had a faculty member who was certified blood bank person, but she was not a clinician. So I said, okay, we will sign it and you just do the cross match and keep the thing. So in case we need, you will give us blood transfusion. And then I brought in advance of 50,000 rupees and a transport for Anant Kumar. I said, go and buy everything what you need to start a operating theater. And we did our first transurethral resection, and then there was no going back.
It was in 1989, 90, somewhere like that.
89. It was the beginning of 89. It's almost
Then
say that, yes, maybe end of, no, 88, 89, we did first transplant. It was 88.
when the funds start flowing and then department suddenly grew up.
Yeah. No,
In the matter of 10 years, by 2000, my God, it is up exactly competing with the aims.
No, because let me tell you that why the growth was there. Because this UP was a starving place.
Okay.
Only urology was 3 places. My respected friend, Dr. K.M. Singh, used to do transurethral. He was trained in England. He would do urology at KGMU and in his private practice. He would do a very good urology, let me tell you. Similarly, Dr. B.D. Sharma at Agra, he was the doyen of transurethral resection and he had his experience of England. That was another place. Third was Dr. V.N.P. Tripathi, who had come from Lahi Clinic, and with Dr. Ambasta, they used to have a urology department there. So this is all urology done for 120 million population at that time. And it was a starving place. And we were flooded. SGPGI had no time to breathe. So administratively, it was a disaster because there were so many patients for us and our infrastructure was not ready to take that amount.
So when did you become the director, sir?
It was 97, first time I became director. I was doing, this is very interesting that 95, molecular biology was on peak and we would do journal club and our molecular biology and biochemistry was very weak because we were not taught that much in undergraduate and we never did basic research. So I felt disgusted and I said, look, I think it looks like that within few years, I wouldn't understand the language of urology. So I decided to do a sabbatical at the University of Gainesville at Florida with Perin Chandnarayan, who was the researcher's urologist at that time. He became chairman. He gave me a fellowship. So 1 year I worked in the lab, and 96 I came back in the end, and 97 I took over as director in the March within 3 months of it. And then
So how long you continued? I mean, after taking it, how long you continued as director of the SGPJ, sir?
I did 3 years of directorship. I could have continued there, but there was some administrative problem with the governor. So I decided to leave and did a sabbatical at Apollo Hyderabad with Dr. Reddy, establishing their Medversity, the first Medversity digital medical education portal, which is even now doing well.
Yes, we remember that your short period. I am from Hyderabad, so I remember that I was remembering as NIMS director, but later on I came to know that you went to Apollo.
NIMS, you are right. NIMS, I have still an appointment order from NIMS. When I there, Dr. Kakarala Subbarao was was the chair of committee to select the director for NIMS.
Yes,
he contacted me and he said that why don't you take over? So I said, give me an appointment order. He gave an appointment order. In the meantime, I was called back, and exactly after 11 months, I went back as second term for the.
Yes, I remember in 2002 when I was joining PGH Chandigarh, this has happened something 2001, 2, 3, somewhere around this time, sir.
Yeah.
If I am not wrong.
Yeah, to 2000, no, it was 2001. I again took a second batch of director. And before I completed my term, about a year before, I was asked to take over as the Vice Chancellor of King George's Medical University in 2003. I didn't complete the term.
What is the major difference between the urologist, head of the department, director, and the Vice Chancellor? As a personal point of view, your abilities, your vision, your execution, these 3 points, how it is different? Quick answer.
I have a full presentation of pivot sometime, pivot or stealth.
We will do again one more time, sir. But honestly, what is in your mind? For example, when you are a urologist, you are craving for the patient care. A doctor you have seen up to 4 o'clock. You are a good surgeon. You have a team. You wanted to develop the department. Suddenly you became director. You have to see 10 departments and do justification. Suddenly you become a vice chancellor, which is a much more administrative headache. What was in your mind to do so much variety of things in a short period of 10 years?
Let me tell you that it is very simple, that you and I or human beings are a bundle of attributes. Today I tell you that where did you get that skill set from? You won't be able to tell me, because we are in a constant school of training in the life. Life teaches us. Now, what I said, that whenever you go to, after some time, you have to leave your role, you have to behave in a different way. So when I was individual faculty, I was working for myself on learning more and more and more. When I become a head of department, the other faculty members become my responsibility. It is not me anymore. It is them. When you become a director, then urology is soft corner, because when I became director, I was honest in telling in first faculty meeting that there is a definitive bias. I can't do it. Urology will grow, but not at the cost of any other department. So director means first thing you have to come and tell those who are close to you, it is a difficult time for you. You can't get away because you are socially close to me. I have people who are not unhappy, those who are unhappy with me. So you have to keep changing the role. And that's what I tell my colleagues, that if you will start competing with the residents and your junior faculty as a head of the department, you have not changed your role. You can't cling to your past. You have to move ahead and do different responsibilities.
Great. That is the point I wanted to listen. And last part of your journey, when did you leave India and why? As you honest reason why you wanted to make into the robotic system, do scientific research, or for the children's sake, or for family, or any other reason you moved to US?
Well, let me tell you that I did not move for any reason. I had a wonderful career, as though it was a very stormy period of 3 years as Vice Chancellor of King George's University. But I made a new hospital. It was 200 crores ground investment in UP in that place. So it was a very satisfying tenure, and my governor wanted give it extension. He said, "You change your mind, your file, I'll keep you come and." But somehow or the other, my friend Mani Menon at that time was at the peak of
Career.
robotic surgery, and he wanted that. So in 2005, I visited him on IRIS symposium they used to do. They invited me for that symposium in Detroit. And while he was dropping me to the hotel, he said that, "Why are you wasting your time? You've done enough of administration. Let us do some quality academics." And that is the time I decided in 2005, and we didn't discuss anything, but then I came and decided and told my wife, and my son was a medical, he was already a fellow in basic sciences at the Henry Ford Hospital. So that was another attraction, not that I came because of him. And then in 2006, I decided to come here. And
What
coming
was
here,
what was your assignment role? What was your target? Have you taken it seriously, or you wanted to start it like post retirement, something new I wanted to take, or you have taken it seriously, one more project?
well, let me tell you that retirement is not the word in my
Yes, sir. I want to. I'm sorry to use that word. In fact,
I'm
uh,
telling you, is to convey that retirement is a mental fatigue. And if you have
yes,
a
sir.
mental fatigue, means you are not at the right place. You are not doing what you should do. Age has
Yes, sir.
nothing to do with your energy level and enthusiasm.
Yes,
Anybody
sir.
can get my age, and I don't think I work less hard than what I worked in my 30s. So
Great.
retirement was not my point, and money was very open to me, and he was not clear where would I fit. In fact, he had concerned that a person who was heading institution with 10,000 people, 300 professors, how we
Yeah.
will exist in this environment. So he had his apprehension. Now in cool moments we discuss, but I came with the open mind that I wanted to research my restart my career. I wanted to have come here with not my past laurels but new thing. 2 years I did his database. We set up RoboSearch, which was one of the best data sets, and 2 years we did that. And somehow or the other I said that I understood US is not a place you can survive on even day back glory. So I said money will get fatigued because I'm not bringing any revenue for him, and how long he will do. So I decided to do MBA in at the age of 62, and money supported me, and I did an MBA from one of the best institutions, the Ross School of Business, which was Ann Arbor. And after MBA, my whole outlook changed. And then Mr. Vatikuti approached me whether I could run his foundation. So now, you know, what I wanted to say that whenever you blame an employer, blame yourself. Because employer will keep you as long as you add value to the organization. And if you see only India where you after 10 years of professor, you keep on rolling paperweights and nobody will touch you. People will respect you more if you don't do it. But United States is a place where you have to proactively keep kicking your career. Even after that, I didn't leave it. After my MBA, I ran the foundation. I still do research. I do new procedure developments. I teach. But then I said, look, now it's 7 years, 10 years, I should do something. And I got in for 4 years ago, I got into artificial intelligence. Now I have another consultancy to do the process flow engineering in one of the major hospital systems in US. So you have to proactively find something which will keep your neurons excited.
Sir, before going to the topic of 10 minutes artificial intelligence with your slides, now for the audience also, there should be some message. This itself, whatever your journey, you told a couple of important points that what I'm understanding is that you have changed positions irrespective of the fame, irrespective of the status, and survived. what I am understanding is a great character of yours. And second thing is you have looked everything into your positive attitude and brought laurels to the place where you have gone. Now, for the younger generation who have passed out MCH, just basic information is that 350 urologists through DNB and MCH are coming out every year in India. I am talking only in Indian perspective because I don't have much knowledge about the world, and all of them are highly competitive, and they all have basic desire to excel in their fields. Some wanted to write USMLE and go after 30 years. Some wanted to go to private practice and earn money. Some wanted to go to the institute somehow, and some wanted to work with some boss. They may or may not get it. Now, if you see all the four, we can't decide the destiny, but for the sake of discussion for the juniors, what should be the attitude in the first 5 years after they come out of the practice? To be honest, none of them will be in a position to get their basic items like food and dresses, which was there previously 30 years back. I may accept, but now everybody will earn around 50,000 to 1 lakh rupees. They can plan their first 5 years of career. After that, they can mold according to the road or according to choices. What do you advise for first 5 years to the MCH passed out students? How they should think in the present era?
Look, first thing is set the concept right. You say 350 pass out every year, they may be 3 and 3.5 million passing out.
Yes, sir. Yes, sir.
Don't forget your character. God has made each one of us unique.
Yeah.
And honestly, I'm telling you, in my career, there was no competition because I never looked at others. We never looked, we knew, but we never compared ourselves with any other institutions. I read a quote from somewhere: be clouds to set your standards, not copy them. So always it is with you, within you. If you get something good, you should pat your back. If you don't get it, don't find alibis and excuses that because of him or he's related to the so-and-so or he's influential. So first thing is develop your inner strength and don't get distracted by the others or competition. Competition is at a mediocrity level. Competition is never at the top. I'll recommend a book, Jonathan Siegel. Read that, how you should be different than others. So I think that's absolutely no question that. And second thing is set your priorities right. There are three things, Chandra, we crave in life.
Yes,
Number
sir.
one is the work satisfaction. You should be happy at the end of the day. Number two is the money. And number three is the fame. In my career, 2 and 3 were byproducts.
Yeah.
And then you break it down, it's not that if you have looked after the work in hand, a particular patient, including a very trivial thing like his catheter is giving a discomfort, and put your head in and change the size of the catheter, talk to him, make him comfortable. That is the basic brick you have to lay. Don't be lost in the future psychedelic, I'll do this and I want to do that and I want to make 9 hospitals. They will come up. Look at your own story. They will come of its own. Basic unit is what is your character, what are your bedside manners, what are your priorities. Try to learn everything rather than teach. Others are to teach you, not to turn. So that be a good listener than a talker. And talking will come to you as an opportunity.
Yeah. Sir,
You
hello.
put ads in the newspapers and all. People will pick up if you have the basic traits that focus to yourself and not on others. There's nobody else exists for me.
Yes, sir. Good point, sir. Last couple of questions before we go to the presentation. Basically, as the life, I believe in that the day you are married, you are an administrator. In the current era, when you are dealing with people, if you want to go and do the best job what you want, even if you are sincere to your patient, for example, you are there in the institute, unless you have gone to the director and put on paper whatever may be the relation, It is administration as far as my knowledge is concerned. You're only within 1 month you do erythroplasty, and then you did later on next year only transplantation. Where the students see enormous amount of the efforts have been put to become a doctor without knowing what they will do, and now after the MCH also a lot of people may not know the communications and administration at every level. Administration, you did MBA at the peak point, then you are saying that it is very useful for me. What a surgeon particularly dealing with at least in the OT staff should know in their life as an administrator, whatever the form it may be, private practice, institute head,
I think
administration.
basic thing is administration and management is nothing. Its basic unit is how do you manage yourself? That's it.
Okay.
Because then, everybody likes to be treated like you would like to be treated by your director. So if some director or head of department did not treat me well, I don't develop a vengeance to take it out. I put it in my occipital lobe. This is something I'll never do it as and when I reach to that position.
Yeah.
And if there is something good, you pick it up. But let me tell you, in the same breath, that just focus on doing what gives you happiness.
Yes.
Just focus. Don't depend yourself on others. Others will come to you. It is entirely you, and you. And that's why I recommended the talk should
You are the architect of your career.
bringing the point that no word can stop you. Let me tell you, you talked about transplant. You know that in 1975, I left CMC Vellore. After that, I struggled to do transplant in Zipmer, but there was no nephrology or no dialysis facility. No patients were coming. Infrastructure was not there. It took me 15 years to start the transplant on my own at Sanjay Gandhi in July 89. But I continued. I didn't leave that thing. I used to do auto transplant. I'll meddle with vascular surgeries, and there was no problem. So whatever are your aspirations, don't throw them in disgust. Keep them at the back of your mind and wait. Have patience to wait for the opportunity.
Sir, last question. We all talk about this. We all learn. We have ambitions, but sometimes we fail. Sometimes patient death happens in private practice. Again, I am keeping this in taking the juniors into picture. Sometimes entire erythroplasty fails. Sometimes patient attendance will fight. Sometimes court cases will come. In the career, you will go up and down. Some people went to US, they learned good and come back, and they will not be able to do. Even now, I have ambition to buy the robo. I cannot do it. I am doing all the cases lab, but I always feel that let it naturally come. I am waiting. My time is my life is also moving on. So every phase, how the younger generation to take the failures, this is the last question, sir. How should we look at the failures? For example, some failures are financially, I'm not talking about, related to the profession. In the town you may be defamed, you may have pressure from the colleagues. How you might have faced many like that, some personal failures also. How do we take it and go?
You know that some may remember my active days in Urology Society meetings and all. And always I said that present your complication, not what has gone good. And that is testimony is my Himadri Sarkar oration in Banaras during my presidency. My talk was that it is my obituary, and 4 cases I presented despite so much of experience in urethral strictures, they failed to me. I said how I would be remembered. I would be remembered by the families of these people whose, despite my best thing, end to end of a lower stricture, I would never dream that it would fail. I wouldn't even put the catheter, but it failed miserably. So what I would say, failures are your learning. Only thing is, let me tell you, patients like you or anybody who does surgery have died on table in my hands. But then No going back. Even those families are my best friends till today. They said, Doctor, we lost a young family member, but we are satisfied. Nobody else would have done better than what you did. The day he got in complication, you were sitting in ICU. You used to come 4 to 5 times. You looked into our social comfort. So please separate out surgical complication, because usual approach is that all those who are praising you and inflating your ego, you devote time with them. And anybody who has had a bad outcome, you try to avoid him. Don't take his call. Don't talk to his family. I think my focus was on what did not work in my hands. And my attitude was that what can I do next? Only thing I can do is to be with the family and comfort and be honest and confess. Like, first, I'll tell you, first acute rejection of the kidney happened. I was nowhere in the operating room. I was sitting after 250 transplants. I was sitting in director's office, and I wouldn't name, the surgeon called me, sir. I released the clamps and this kidney is blue and I don't know what to do. I have revised anesthesia. I said, I'm coming. I know what it is. We never had acute rejection, hyperacute rejection on table. It was hyperacute rejection. I was not in part of the surgery, nothing. I took the clamp out, and as a team leader, I walked out to tell that this 27-year-old man has rejected the kidney. I talked to the family and I said, we'll do everything possible to help you financially, whatever we can do, but take responsibilities of what you do. Don't shy away from complications. There would be bad moments. Press will play havoc with you. Let them play. But you do your thing, that your job is to look after the patient. Do you, Chandra, guarantee every patient that he
No,
will
sir.
be?
No, no, no.
Can't. All you guarantee is you will get the best out of my hand. And then anybody, Dr. Kulabalawala used to say that anybody who says his results are 100%, either he's a bloody good surgeon or a bloody good liar. And chances are that the latter, he's a bloody good liar. So I think don't worry about complication. They will happen. Only introspect, replay these videos, talk to your colleagues, see what else you could have done and try to avoid. Still, they will happen. They happen at every part of the career, because that's why surgery is hard taskmaster.
Yes, sir. With this, I will share a few photos which I have in which you are there. So for the audience, even though it is not surgical technique, this is very important. Most of it is we have discussed. One thing, few things which I have not discussed are Dr. Bhandari sir has received Padma Shri award. Naturally, in India, this is award which is very important, given by the government. So this is the one thing we missed. This is given in 2000, and if not to be mentioned, he is the CEO of Verticity Foundation since 2010, which has changed the entire surgery. In fact, entire surgery, not only the urology surgical profession, by bringing the Da Vinci Robo and then promoting the Da Vinci Robo and then making Verticity Proud Institute, which is again related to the Indian surgeons, both of them, Bhandari sir and of course Manimenan sir before. And the rest of the things, we in 1984 Indian Journal of Urology is established. I didn't know this. Today when I was reading this CV, I understood it is a big move. And he is vice chancellor. That also today only I came to know. Chhatrapati Shivaji Maharaj Medical University, such a legendary personality, and he told two three couple of things. Anybody who listens will understand that. The SK Sharma sir was my teacher, professor when I was. He is the last 1 year or 2 years of directorship. I was a chief senior resident with him. Bapat sir recently unfortunately passed away, and along with Bhandari sir. These are legends who have made the principles of surgery, principles of the behavior, ethics into the system for last decades. And Dr. Pandey sir, Dr. Pandey's son Arvind Pandey is my junior in Chandigarh, and then Dr. Bapat sir and SK Sharma sir. I don't remember the central person. This is the way we miss Bhandari sir.
This is Dr. A.P. Pandey.
A.P. Pandey. Okay, both of them are Pandey, sir.
No, this is what you call Panda.
Panda. Okay. Yes, sir. I didn't know him. Sorry for that. And again,
from Rampur, I mean say Odisha.
Yeah.
And
Yes, sir. Yes, sir. So, Dr. Ganesh Gopalakrishnan, sir, again a man who is very active. Raju Kumar, now known for his academics. Raju was my when I was doing MS AIMS, he was final year resident under Dr. NP Gupta and Dr. Hemal, sir. And this is the audience. I recognize some of the Dr. SK Singh, others. Are there in this picture. These are some moments with Dr. Bhandari, sir. With this, because it's an clinical presentation, we will like to talk a few slides what Dr. Bhandari sir is presently working on, that is artificial intelligence. Let us listen and then conclude the session. Sir, over to you, and you can share your screen, sir. Thank you.
Thank you, Chandra. It was a wonderful discussion. And as I said, 4 years I have been working on artificial intelligence, and I have a technical partner, a company. And I am working with two basic principles, which haunted me as a surgeon for almost 5 decades. One of them, surgeon has an extremely poor predictive value. You know, what you do, what you propose, it never happens. Uh, Even a move of an instrument is responded in an unpredictable manner. You know, you are very careful in dissecting, and suddenly a spurt of blood comes or you injure something. So we are trying to bring more predictability to surgery, because surgery is totally surgeon dependent. Experience of the surgeon is more important. And if you take 300 cases to benchmark the erectile dysfunction as a learning curve, then you have to concede that 299 patients suffered because you were not fully trained. And with that premise, the why everybody compares that when autonomous cars could be driving Tesla, but why the surgical robots are not become automatic. So I want to, in brief presentation, tell you the bottleneck is not with the technology with the companies, but it is with the urologists or the surgeons. And because these models need high amount of label data to turn into algorithms. And if surge and this labeling of kidney or gonadal vein or inferior phrenic vein cannot be done like outsourced for birds and pigeons and dogs and monkeys or face reading. It has to be done by the urologist. So this slide is to coax you to get involved with the process of data building. These models, if you see that this is a model where you see that this is the real-time surgery of spleen, vein, and artery in a donor nephrectomy, and model accurately recognizes everything. So the whole idea is we really want to turn these models, and once we have very successful models, we will really turn them into robotic tools. Because the process is, once you have a model validated, tried in clinical trials with the feedback loop, you can turn them into robotic tools. So the bottleneck is not robotic technology. Bottleneck is the data, labeled data and accurately labeled data, and which a urologist has to do. So the objective of this was, I'm trying to describe simplified process, because AI, everybody talks, but we think that it is a job of algorithms and R language and technical thing. No, it is basically urologist has to work with the team. What we had was we have collected, we have collaboration. You would have seen the name, 22 videos of live donor nephrectomy. I chose live donor nephrectomy because it is closely normal anatomy. And then we have worked on 6 videos. And mind you, the mind-boggling data, 1.5 million image frames we process. Ultimately, to have a data set of 2,164 images after several processes of filtering into a training data set. The data guideline is the end-to-end workflow for this is that raw surgical videos are taken, then they are curated into raw frames, and then the annotation jobs are created. And then three independent annotators on a tool we have created would annotate this data. And then raw annotated images are again cleansed because erroneous labeling or discrepant labeling data is removed. And once the data is ready, then it is fed into 4 neural networks we use to turn them into the models which I showed you. This is a very interesting tool. This is because of the urologist's involvement. We had a problem that urologists would like to download or send a movie. They can't send it. Of the surgical videos are 2 to 3 hours long. And so we created our own platform. And this platform, any one of you can participate. You control your data. You collaborate, and it's a very fair kind of distribution. Currently, we are talking of publications. And if you contribute your data and if you label your data, we will be able to, and you keep the control of your data in your locker. And the day you decide, nobody can take your data. And then this tool would let us build the models or the process, the annotation process, in a very secured environment. In some countries have GDPR and all, we can do it in their cloud servers. So it's a universal data because we are starting to have a movement of academician turning into a consortium with equal partnership to provide large amount of data. Now, you see, this is the annotation process. How you do the annotation tool. Here, I would like to stop and show you that, look at this. We identify spleen with our visual perception, but there are 3 textures of spleen, T1, T2, and T3. These are 3 different textures. Networks recognize according to the texture, color, and the shape of an organ. So if you initially we labeled everything as a spleen, network got confused. Now we have to train these 3 different models to recognize completely spleen. So you have to develop a culture of what you call, and it's not enough to know your anatomy. I'll jump this slide, and now you see that this is how the vessels are being labeled. But this suction is not of the same texture. So annotator has to exclude the suction. This is an aorta. Until we do the complete annotation, the people will, the networks will get confused. Now, this is how the better artificial intelligence, better human intelligence. A trained model with diverse set of annotations is capable of correcting annotator's mistake. Here you see, annotator did not label the vein correctly, but the model picked up the renal vein. Annotator forgot to do the renal artery, but annotator, the model picked up. So artificial intelligence is something, these are certain things we laid the ground rules for labeling, that this person did the renal vein and correct spleen, but he forgot to do arteries. This is a bad annotation. This person did renal vein and renal artery, but forgot to do an spleen, but forgot to do a branch of renal artery. It's a bad annotation. Complete is that you should be able to annotate all the classes given in a frame in a uniform pattern. This is the correct annotation. So this is the culture I'm trying to say. This shows that, this graph shows that how after consensus building, we improve the performance of the model. Red bars are after consensus and they are before consensus. This slide just proves the point. Urologists are the ones who help, particularly Italy models, or the clinicians are the people who help jacking up the performance of the model. Don't get scared, get involved in it. And here is a model which, our model which performs. You see that renal vein, it is a contemporaneously. This is renal vein, green. This is renal artery. This is renal, and you will see the spleen very shortly. So I think the point I want to make here is that, just to introduce you with the subject, artificial intelligence, everybody keeps on asking me a question, when would the automatic robot come? It will not come. I am very, very clear. till the urologist or clinician resolve. They learn the art of preserving data culture. They have to collect more data points, how the data should be done. They have to understand the process of model building, and then only we'll make progress in this direction. I think this is all I wanted to add of what I said.
Thank you, sir. Nice. You have chosen an area where even not only in urology and not only in the medical science, everywhere people are using artificial intelligence. That everybody knows now, the digital information, digital science is going to take the future. With this, we have spent 1 hour with you, sir. As expected, 303 audience are there online. That itself will say the importance of your talk, and I really appreciate that. For the audience, this talk will be there forever with the same YouTube link. Anytime you click from beginning to end, you can.
Only I have one request. Please display my email address. At this point in my career, I have no ambitions left except for helping every youngsters, and I don't help them by getting a recommendation. Most of them come thinking that I'll get them a residency. No, I work with them to see that they realize their own potential and get it as a claim and not as a mercy. So you are most welcome to let anybody know. And
you wanted to say your email, or should I type in the chat box? Both will be there forever, or let them find out.
Yeah, so I'll be very happy to really respond to them promptly.
Yes, sir. Thank you very much, sir. I really appreciate the way you brought your career, and I wish you will do more and more to the world, not only to India, and give laurels to India, of course. And really a great journey. And in fact, for me also, it is a personal achievement that I could talk for 1 hour like this with you and get the information. Maybe it will generate some different thought. You said 300 and only word you counted is 350 euros, but you said, Chandra, 300, 400, 3 million also. Forget about it. There is no competition. Competition is in the central part, it's not in the top part. So you like what you want, and you grow upon yourself, and you set your own priorities according to your happiness and desires. Then you will grow. That has a lot of sense for all those who are in fear of competition.
Only parting thing I would like to say, the last sentence, is that don't be distracted by what others do.
Yes, sir.
Try to make buildings and make property. No, nothing wrong in that. But then don't expect that you will be happy professionally in your career.
Yes, sir.
Yes, sir. Set your pride. There is nothing wrong and nothing right in life. But if you sow seeds for apple, then expect apple. Don't skip you.
Great. So thank you very much, sir. Definitely love to have some. This will. I'm planning to continue at least weekly once like these programs. In future, any specific subspecialty interest, we will talk. This is the first time I have interviewed only about career, because your career is like that, and it will help the juniors. Thank you very much, sir, for your excellent talk.
Thank you very much. Thank you so much.
Thank you, sir. We will conclude.